my talk this morning is about retrograde, and I think it re-emphasizes the case that we did yesterday, that James did. It was actually just emphasizing the points that we went through. We all know it now because the case last night had every single issues that could happen, could go wrong with the retrograde was there, and James and Shireen and everybody else here helped and think about how to really go algorithm within an algorithm, and the patient did very well. So it's basically re-emphasizing a few of the points, and as you've seen yesterday today, a lot of these talks are interchangeable. It's complementary to each other. We're trying to dissect every single aspect of this procedure into a small little talk. So as we talked yesterday, there's a couple of ways in general to do these CTO procedures. It's either integrate or retrograde. Most of the time, as we discuss again, is that we try with an integrate, and that fails. You have to have retrograde skills to bail out and finish the case. However, what are the issues with the retrograde is that the retrograde procedures in general associated with higher complication rate, including especially the one we fear a lot about is the perforation, cardiac tamponade, pre-procedure MIs, and et cetera. So be very cognizant about these risks associated with retrograde procedure. Like any CTO procedures, it all starts with proper planning, and the steps of planning, you take it one, it's like a checklist of flying a plane, so make sure you go through this checklist to achieve what you need to achieve. So we said that yesterday, so first of all, you have to do the imaging without you having any nystagmus, so this is not an image that you can use, so there should not be any panning. Almost always, if possible, you need to have a dual injection, because dual injection without panning could help you plan and decide on the procedure, which things you're going to use. So when you do retrograde, when you say retrograde, so how are you going to come retrograde? So you have to use some channels to come retrograde. So there are 3 retrograde options in general that you can use. So either septal collaterals, or epicardial collaterals, or vein grafts. Vein grafts could be an open vein graft, or diseased vein graft, or even an occluded vein graft. And there is we will have a talk about this, specifically how to use a CTO in post-CABG patients. And actually today we have 2 cases post-CABG, pretty interesting cases today. So if you want to do the CTO retrograde, try to use the vein graft as number one. When you're starting, use the vein graft as your collateral option, number one. Then escalate your skills to the septal, and then escalate your skills to the epicardial. For the septals, the couple of small tricks is when you shape the wire, you have to access the septal and then you change. Don't use the same wire where you access the septal, because you need to have a specific bend to reach that septal. However, when you're inside the septal with your microcatheter, the wire shape should change to, as I've shown in this slide. So the specific shape on the wire for the septals. And as we discussed yesterday, we access the septal with a workhorse wire, then we are in the septal, then you have to think in your, you have to think which wire am I going to use to cross the septal, and in general think about cyan black today, and SUO3. SUO3 we use it when you have an extreme tortuosity. Cyan black is a good wire when you, like James showed us yesterday, if you have an invisible septal communication, cyan black is very, very good, and then you have the cyan. So in my algorithm, when septals, I go with cyan. Cyan didn't work, I go cyan black. The cyan black didn't work, and then I realized after assessing the collaterals, I may go to SUO3. But 20% of the time, you wouldn't be able to use those septals anyway. So if that didn't work, you use another septal and keep trying to change. The key is don't get stuck in one mode. If that mode fails, it doesn't go, just come up quickly and change your strategy. So this is how the septals are assessed. But then the question would be, what is an ideal septal? Right? So this is an ideal septal. This is taken again from James' book. And an ideal septal is that from the donor artery, you have a fantastic angle that you can access it. The collaterals have no tortuosity, no branches, and the exit of the septal is excellent exit. But of course, that does not exist in reality. The other thing is, once you go through the collateral and coming back to your target vessel, you got to understand the concept of I call this the attack angle. So if you come from the collateral with a distal RCA lesion like this, your attack angle is very short and acute, and you would not have enough push power. But if you come with an attack angle like this, is much better. But there's also a solution for this, right? What's the solution? If you come retrogradely, and they have a distal cap in here, and you have a short attack angle, you can't push enough. You escalated the wire, you can't push enough. What's the solution? So you're trying to dissect, you don't have enough pushing power. You want to increase your pushing power. So bring the microcatheter as near as possible, and you're doing that is pushing everything out to you.
Change the wire.
Escalate the wire. What else? Any specific microcatheter? So, changing the angle of your wire? That's the key. So you can use a dual lumen microcatheter, and the Suzuki is a dual lumen microcatheter that you can use it for retrograde. The other ones are bulkier, so the Suzuki, you can use that. You come like retrograde, and you put your Suzuki right in here, and then you really have a good pushing force. You know, scoring system is our scoring system. There's also scoring system for collaterals. And Margaret, is one of our colleagues as well, has done extensive work and it's been published, but it's really, really good because it gives you an insight of how much detailed attention people pay for these collaterals and how much you really have to sit down and analyze these collaterals. It's not uncommon, it's absolutely very common when you do a case and the patient has fantastic septal collaterals. You look at it and then when you try, you will be stuck. You keep on trying and you can't cross. The reason behind it is a couple of things. One, the image was done really was not without panning. The second reason is you did not appreciate all these components of these septals, that the entry point, the tortuosity, and exit. So when you try to do these septals as well, please pay attention. Take good images to assess and evaluate these septals. They're very common for the LED to RCA. If you take an REO or REO caudal or REO cranial, and you analyze these septals one by one, sit down, look at it in a detailed fashion. Then what is the optimal view for these septals? When you look in one view, they may look like this, look fantastic, straight, no tortuosity, but occasionally you have this and you have to come down and turn and up and this and so forth. So take an REO view, take an LAO view as well, you can assess these septals. Coming back to wiring the septals, so the three wires, keep in mind, cyan, black, and suo. So if these septals, in I think about 20 to 30%, you have septals connections which are invisible, and if you try this regular cyan, you couldn't do it, go with the cyan black and try to really, as was shown by James yesterday, even to go quickly through these septals and try to do a surf through it. Keynote, you only surf septals. You don't surf epicardials. So an example of septal surfing, we've already accessed the septal, change the wire, get a cyan, and go quickly and really rotate the wires. You don't rotate much for the suo. You can rotate the cyan, you can rotate specifically cyan black, but not the suo, because suo, as I said yesterday, it could go into this tortuous septals and form a knot, and then you have a gear entrapment. Okay. Occasionally, you try to do the septal surfing and nothing happens. Then you have also the option of do the tip injection. So you put your microcatheter in the septal, Take glass syringe like the one used, OCT syringe, this strong one. We have all the other specific syringe called medallion syringe. You take 2 cc's of pure contrast. Make sure before you inject through this microcatheter that you have a backflow. If you don't have a backflow and you inject, actually you're going to rupture that septal. So make sure you have backflow. Make sure your microcatheter is not wedged. If you have backflow and it's not wedged, inject and have a look, see if the septals are communicating or not. So the tip injection, I think there's some communication there. And then you can use the wire and surf and try to get to the distal segment of the CTO. You see, these are the tortuosities. It could be something like this. And if you see very severe tortuosity or something like this, then you may think about starting with a SU03 wire. SU03 wire, when you use it, be very gentle with the wire. It's a 0.3 gram tip. So don't push it too hard. Let the wire work for you. So you just a little bit of touch, a little bit of rotation, and then with the heartbeat, the wire actually would move forward. So a tortuosity such as this, I would probably use cyan. If cyan didn't work, I would change to SU03. The other thing about the crossing the channels, don't keep your microcatheter very close to the tip of your wire. Why? Because that would increase the tip force, and that would not be counterproductive. You want the wire to go through this. So as the wire goes forward, advance a little bit. Don't make them within 10 or 15 millimeters from the tip of your wire. So now we cross with the wire. Now we need to cross the lesion with the microcatheter. We had a very elegant talk by James yesterday, different types of the microcatheters. And I think it's like the wires, you need to know which microcatheter does which for you. So if it's a very tortuous, extremely, like the case we had yesterday, is remember, James went through the septal and the microcatheter was stuck. So then he increases support with a guide extension, it was still stuck. Then he dilated the septal, and then he actually used a very lower profile microcatheter such as a Caravel or Turnpike LP. So you need to think about, okay, I'm going to use a microcatheter to cross the septals, but you want to know which microcatheter based on what you think is going to be potentially the problem. And you can see the different types of the microcatheters. How you move the microcatheter, again, as I think I'm repeating it again because it's also from James, and it's a two-hand technique. With your left hand you push, with your right hand you rotate. One technical tip I tell you is don't over-rotate too much. So I mean 10 to 15 times is probably max, and then push and pull, because it may actually, you may end up having a fracture of the tip of your microcatheter. In general, the two microcatheters currently that you're not supposed to rotate is the Caravel and the Fine Cross, because you could have a tip fracture, especially Caravel. I certainly had one, so please just be careful with these rotations. So now we have the wire in the distal cap, we have the microcatheter distal cap. Then your question is, now you're coming retrograde, what is your next step? Are you going to cross the lesion wire? There's a wire case. What we're going to call that is retrograde wire escalation compared to antegrade wire escalation. So you can, if it's a very short lesion retrogradely, and you can actually finish the case with just wire escalation. So if you have in the distal bed a sine wire, you escalate to Gladius or Pilot or Gaia second and cross the lesion. So that depends, again, as we did for the antegrade, depends on the complexity of the case. Right? So if it's short lesion retrograde, then you went retrograde late, so maybe you finish the case with a wire. However, if it's a complex, very long, tortuous, calcified, very likely with the wire escalation would not going to work. And again, going back to the case we had yesterday, it was a very long, calcified, tortuous case, but it wasn't a wire case, so James had to do knuckle both sides and do a reverse scar. So depending on the complexity of the situation. I like this slide very much. It's from the, I think, CTO group in Japan. It's an old slide, but it gives you an insight. If you decide to go retrograde 100% of the time, to reach the collateral channel by the guide wire, you will reach there 82% of the time. And if you reach the collateral channel, to reach the if you cross with the guide wire, through the collateral is 82%. So you cross with the wire, you have 82% to cross with the wire. However, if you cross the wire to the distal cap, what is the chances that you will cross with a microcatheter? 76% of those cases. So you cross with the wire, you cross with a microcatheter, so the chances after that to fail is only about 7%. So when James crossed with the wire on distal right and crossed with the microcatheter, now we know that his chances of success is 93%. And James had probably 99%, but that's data that you have. So once you reach the distal cap with the wire and the microcatheter, so feel very confident that there's very likelihood that you will succeed. But if you did not cross with the wire, the distal cap, and you try different times, it's very likely that this retrograde option is not a good option. So in general, you won't be able to get in retrograde access in 24% of the time, unable to complete the case 29% of the time. But I think in the current era, the numbers are much better than this. The reason behind it is the advent of the cyan black. At that time, there was no cyan black. It was the FC wires and whatnot. So the cyan black wasn't in the market yet. The other thing I tell you from my own experience learning as we do it every day, and when you look at these cases, whether they're online cases, they're available on the YouTube or even conferences, and you see, well, you go to places and no one talks about cyan black, right? You come to Bahrain, we're talking about cyan black. You go to Column, you'll be talking about cyan black. You go a year ago or 2 years ago to CTO in New York, cyan black, no one talks about it. And the reason is because the cyan black is not available everywhere. It wasn't FDA approved, so people haven't had the experience using it. So if a geographic location they're not using a certain wire, which I think is very useful, it doesn't mean that it's just because it's not available. Now that it's available worldwide, you see everyone talking about utilization of cyan black, especially in the very difficult and invisible septals. So it's like a movie. You see what's going on, where is it being distributed, and who's using it, and how you learn from the different experiences in the world. So now we crossed with the wire. Now we need to connect the dots. So as we said earlier, either you cross with the wire or you do a reverse cart, which was shown very elegantly yesterday, the case of reverse cart. You come back, you balloon from the antegrade side, make a space, and try to, from your retrograde area, to actually connect these two spaces. So and you have to use, occasionally, if you're actually if both wires are in subintimal space, it's very easy actually. If you're antegrade is subintimal, retrograde is subintimal, you balloon antegrade, you make a fenestration, wire goes in, and your guide is done. Yesterday's case was difficult because one plane was in the lumen, the other plane was subintimal. So there's a tissue like this that you have to penetrate to get into the space. So that's why we used yesterday penetrating wires such as the CP12 and Gaias and whatnot to get to connect the spaces. So talked about that. So you do this, and after that we talked about CTO crossing, and after CTO crossing is the wire will go somewhere in the guide or in the aorta. If it goes in the guide with the guide extension, fantastic. You trap it, take your microcatheter up, take that wire back, put an externalization wire, and the case is finished. Occasionally, that's not the case. You try, and the wire doesn't go to the guide at all. But I think this has changed significantly. I mean, nowadays, I rarely use the snare anymore. Well, we used to use more snares in the past because we're using at that time we were using less of the guide extension, but now I think almost all the cases of reverse guide are using guide extension. And the key when you use a guide extension, don't use this. If you have a 7 French guide, I will use a 7 French guide extension. Don't use it because the hole is bigger and you can really go into it easier. But if that's not the case and you still, wire goes in the aorta, luckily, and you don't want to lose that position, you still have the option of snaring it with an EN snare. The snares, they'll talk about this, just a minute to talk about the snare. I would highly recommend the bigger snare, the EN snare 30 or 45. I wouldn't use a loop snare because you go crazy. So you have the 3-dimensional snare, and if the snare goes, and typically when you go retrograde, the wire would go in the brachiocephalic artery, and this is where this is a very, very common place to snare the wire. A tip about snaring: don't snare stiff wires, please, never, because you have a wire entrapment issues. The only wire I would recommend for you to snare is the RG3. And if you look at different lectures, different books, they would say, well, only the soft part, the whole RG3 is soft. So I mean, unless I can snare the RG3 anywhere in the RG, not necessarily the tip, because the whole wire is very, very, very soft. Once you snare it, you bring the guide down. So one operator, your assistant, is pulling and you're pushing. And you go back to the RCA, and now you have a complete loop from the donor artery through the septal, the distal cap, and from the sort of retrograde, septal, and the antegrade guide. I always find the term donor is confusing. And then you have the complete loop. So that's how it looks like in diagram fashion. So you've gone from retrograde, septal, back, all the way up, so you have a really good loop. One thing that I learned as well from a very dear friend of mine from Aswan, and when you have this loop, and you, for example, you're doing the ballooning and going forward and stuff like that, if you have any resistance, don't push. Because especially if you have stented, for example, you went through the whole externalization wire, you ballooned and stent, say the distal RCA, and then the next stent is coming and you have resistance. Because once you have the two wires, you have extreme good support, and you think, well, I'm just going to push. Don't push, because sometimes, as we showed yesterday and we talked about using the guide extension, the stent would hit the other stent and would deform it for you, and then you'll end up in a disastrous situation. So use the guide extension. Don't be aggressive when you have externalization wire. Always protect your collaterals. And once you have externalized, make sure you bring your microcatheter back and protect the collaterals, because the movement of the heart with the wire and the septals, it'd be like the cutting cheese effect. So always protect the collaterals. I think I'm going to skip through all of this, it's a repetition. The other tip you can also utilize occasionally is, once you have your retrograde microcatheter into the antegrade, what we do currently is the wire would come, we push it all the way to come up from the other side. You also could do is you remove your retrograde wire, the microcatheter is there, and you can advance your antegrade wire and put it in, and we call that a tip-in maneuver. And then you can move on and finish the case. There are advantages of that. It is fast, predictable. You can easily retrieve the retrograde microcatheter from the collateral, elegant for distal wire correction. However, the externalization gives you an excellent backup. With this, I think I'll stop. If you have any questions, I'll be happy to take.